Hello everyone, welcome to the March webinar of the Liverpool Dementia and Aging Research Forum today. We've had a record number of people register for this event. We've had much over 500 people registered, so numbers are trickling in. And today we've got Professor Siobhan Riley from the University of Bradford joining us, as well as Dr. Andrew Harding from Lancaster University. And both of them will share their work on what really matters to people living with dementia. So throughout this talk, please feel free to post your questions or comments and thoughts in the Q&A box, and we will pick them up afterwards. So the talk will last for around 35 minutes, maybe 40 minutes, and then we'll have plenty of time for questions and answers at the end. And throughout, if you are on Twitter and social media, feel free to follow us and have discussions there as well using the hashtag Liverpool Dementia. And now the floor over to Siobhan Riley. Welcome to the event.
Hi there. Thank you for the introduction, Clarissa. So hi, I'm Siobhan Riley. I'm Professor of Applied Dementia Research and the Director of the Centre for Applied Dementia Studies at the University of Bradford. So the work that we're going to be talking about today was conducted whilst I was based at the Division of Health Research at Lancaster University. So I'm also joined by Dr. Andrew Harding, who is the Senior Research Associate and Lead Researcher on this study, and he's based at the Division of Health Research in Lancaster University. So another click, please. So I'm going to be talking about what really matters to people living with dementia and what the evidence tells us. So next slide. So in this presentation, oh no, the one before. The one before that one. Okay, the one before that, Debbie? That's it, perfect. So in this presentation, we're going to talk about our core outcome set for use when evaluating non-pharmacological health interventions for people living with dementia at home. So the study was funded by the Economic and Social Research Council and the National Institute of Health Research as part of the Neighbourhoods and Dementia Study. So we hope this study will help to signal a paradigm shift for dementia research in this area, thanks to all the research team listed here who've contributed to this study. Next slide, please. So in this presentation, we're going to cover three main aspects. Firstly, the importance of outcomes when measuring the effectiveness of services. And then I'll tell you a little bit about quite a bit about our research exploring outcomes that matter to people living with dementia. And I'll talk through some implications for assessing the effectiveness of post-diagnostic support. And then Andy will come in and tell us more about the outcome measurement instruments that are used in dementia care research and whether or not these measures reflect the outcomes that matter most to people living with dementia. Next slide, please. So a little bit of background first. So there's growing interest in dementia in demonstrating effectiveness of our care and services, including post-diagnostic support. However, measuring effectiveness is fraught with challenges, not least because people living with dementia have not had a voice in this process. This is certainly changing, and there is an expectation that this must change a lot further. There have been some consensus exercises at outcome measures, looking at outcome measures for people living with dementia already. However, the involvement of people living with dementia has tended to either be non-existent or fairly tokenistic. And there's a lot of inconsistency in the outcome measurement instruments that researchers use, making it really difficult to compare across studies. And that was really the impetus for this study at the outset. So there's a strong argument for researchers to agree on a minimum use of outcome measures and avoid inconsistency in the choice of measures. Next slide, please. So one of the solutions is to undertake the development of a core outcome set that can be used when evaluating non-pharmacological health and social care, community-based interventions for people living with dementia at home. And the aims of our study were to attain a consensus from key stakeholders on what outcomes are the most important, and to enable people living with dementia to have their say on what matters. Then to recommend a minimum set of outcomes and outcome measures that should be measured and how to measure them across all trials within the scope of the core outcome set. So this is what we set out to do about 5 years ago. Next slide, please. Next slide. Thank you. So to address these aims, we used systematic, rigorous and established consensus methods and involved key stakeholders, people living with dementia, care partners, health and social care professionals and policymakers, service commissioners and research leaders in the research process. And we used a 3-phased mixed method study design. In phase 1, we conducted 35 interviews and 4 focus groups with 55 people, and then we also conducted a literature review. So we initially produced a really long list of 170 outcomes, which we then distilled down into 54 outcomes. We also went through a process of getting these outcomes into a suitable format so that people could answer questions on them in our phase 2, which consisted of a Delphi survey and a consensus meeting. So the Delphi method is basically a structured method for reaching consensus where participants complete sequential rounds of surveys. We conducted 2 rounds of Delphi data, and these were 2 to 3 months apart. And then in phase 3, we conducted a systematic review to identify how the outcomes identified should be measured. So the majority of our data for phase 1 and 2 was collected in England, and we made sure that we had co-research involvement embedded throughout the study. So for example, people living with dementia were part of our advisory group. They helped design an accessible Delphi survey, and they provided feedback and input on existing outcome measurements instruments, which you'll hear more about from Andy. When we've presented previously at conferences and events, we've always co-presented with Pam, a person who lives with dementia, and Rita, who was a carer, and they both were involved as co-researchers in the study. Next slide, please. So for phase 2, the 54 outcomes that we extracted from the literature review and identified from the qualitative research with key stakeholders made up the Delphi survey, and this was sent to over 300 people from the stakeholder groups, and then again 2 to 3 months later for round 2. So in round 1, participants were asked to rate the importance of each outcome on a 3-point scale. Not particularly important, important and very important. And in round 2, participants were asked to review the round 1 scores and then the scores of the other participant groups as well. So participants were able to review and they were able to change their responses. So then we had a consensus workshop to attain agreement on the core outcome set. And the pictures that you can see are from that consensus workshop. And we enlisted the support of Tony Husband, the renowned cartoonist. He's the gentleman on the very back row of the bottom picture, if you can see that. He attended the consensus meeting and very unobtrusively sat alongside the discussions, capturing these in his cartoons. So this had the dual purpose of being a visual record at the time of the event and adding some fun and humour, but we hoped that the cartoons would be useful in engaging the public in our work. Next slide, please. And here they are, our 13 core outcome items. What matters most to people living with dementia? So you can have a read through these outcomes. As you'll see, many of the 13 outcomes have substantive overlap with the emergent concept of social health, which is a shift from symptoms, deficit and disability towards the capacity and potential of the person living with dementia. Some of these outcomes we didn't find represented in the trials that we looked at in the initial literature review. So, for example, feeling safe and secure and the importance of relationships and feeling valued and respected by others and having a laugh. Next slide, please. So this is just a screenshot from one of our publications. So we've published all our work in open access journals. I'll show a publication list at the end. And in the longer term, we hope that the use of the final core outcome set endorsed by key research funders will help to reduce inconsistent reporting of outcome data. So trialist researchers and commissioners will then be more able to compare effectiveness across non-pharmacological community-based health and social care interventions for people living at home, people living with dementia at home. Next slide, please. So how might this be relevant for supporting people after receiving a dementia diagnosis or post-diagnostic support? So it will be really obvious to a lot of you listening that many people with dementia find it a difficult process coming to terms with a dementia diagnosis. And what should underpin most diagnostic services is a person-centred approach and continuous quality assurance, evidence gathering, a commitment to exploring and acting on a person's experience of the service, and a commitment to co-designing solutions to challenges identified. So if you're involved in delivering an intervention, you might notice qualitative differences in people who receive or attend the interventions and how they feel afterwards. And it's important to have some ongoing evaluation in the form of service user feedback, which could be along the lines of checking how services affect the 13 outcome items that are important to people living with dementia. So I'm going to highlight just a few of these 13 outcome items as examples of how they might fit with support that people living with dementia might receive after a diagnosis. And I'll also use the cartoons by Tony Husband to highlight these. Next slide, please. So continuing good relationships was rated as the most important item, one of the most important items. And having a diagnosis of dementia means that decisions about who to tell, when and how are likely to be necessary. It's important that friends and family understand the changes. It's clearly a family affair. So the education element of many of the post-diagnostic support interventions is hugely important in supporting those relationships. Next slide, please. Being able to communicate with others and feeling connected with others is highly valued. In everyday lives, people living with dementia often feel alone and isolated, and they may have lost old friends. But when they're able to join in a group, such as a dementia cafe or cognitive stimulation group, they benefit from the chatter, the sharing of experience and enjoyment, and they manage to get their voices heard in a safe environment. Next slide, please. Being able to have a laugh with other people. Indeed, the opportunity for social interaction and the chance to talk and being able to have a laugh with other people is often a benefit from these groups, and not necessarily the aim, but a really good outcome from getting the atmosphere right. Next slide, please. Being able to do the things you enjoy and want to keep doing. The sense of loss that people may feel after getting a diagnosis means that people may need support to be able to do the things they enjoy and want to keep doing. Next slide, please. So, people living with dementia, as you'll see in this next short video clip of our research, get a great deal out of participating in research, and there are a lot more opportunities through the NIHR's Join Dementia Research if you want to look that up. But if Debbie, if you could play the video, that would be great. Thank you. Fingers crossed.
Been absolutely wonderful because I can give something back, and I'm learning things every day. It's wonderful, really. Keeps my brain busy.
You know, when they've said something and I show them the drawing, they go, "Oh, that's it, that's just what it's like." And that's a really nice feeling. It's just a fascinating journey we've been on together. It's a vital project as well, because understanding what people need and what they want, and then to put those out into the wider world, then brilliant. It'd be lovely.
It speaks to me. I'm sure it speaks to others as well who struggle.
Bringing to life what really matters to people living with dementia, having a laugh, having better relationships, keeping their own identity, and it's signposting researchers to these areas.
So we now have Dr. Andrew Harding taking over. Andrew, do you want to continue the talk?
Thanks, Clarissa. Thanks, Siobhan. Can we have the next slide, please, Debbie? So each phase of this project was such a comprehensive piece of work in its own right, and it was a pleasure to work so closely with Tony Husband to bring the 13 outcomes to life in these amazing cartoons. And although I'm in the early stages of my career, I really do hope, well, I strongly feel that when I look back at hopefully a long career, this work will stand out as being something that I remain incredibly proud of being involved with. So, as Siobhan has said, I'm going to talk you through the final phase of the project, where we conducted a review of existing outcome measurement instruments, the how to measure stage. Next slide, please, Debbie. Now, our objective for this phase was to establish how, or even if, the 13 outcome items can be measured. Now, what I am about to talk about is published in a journal called The Gerontologist, which is here, and it's open access to anyone who wishes to view it, which means you don't need a university account or anything like that. Now, I should explain what an outcome measurement instrument is. They are simply questionnaires that people complete, and in this context they typically ask how you feel or how you've been feeling in relation to your health and social life over a defined period of time. Researchers use these questionnaires in studies to try and find out how effective a programme or intervention has been. Next slide. So, given the focus of this work being social programmes and community settings, we were interested in finding questionnaires that people living with dementia complete themselves, so not a proxy questionnaire completed by somebody else, that ask subjective questions, so not objective assessments or cognitive assessments or examinations or anything like that, and are used in social research in the community, so not designed for use in care homes, hospitals or in drug trials, for example. Now, we conducted a lot of searches in academic databases with the terms that related to the 13 areas that Siobhan has just brought up. And after sifting through the things that weren't relevant based on the criteria on this slide, we looked at questionnaires that featured in 357 sources. That included 205 trials, so 205 research studies, 149 reviews and 3 reports. Next slide, please. So this slide, or this next set of slides, really just shows the review in number form. So as I said, we looked at 357 sources. Next slide. We located 347 measures initially, or questionnaires. Now, I just want to pause here briefly and make the point that quite incredibly, that's nearly 1 unique questionnaire used in every source. That's a lot. There are a lot of these questionnaires around, many of which purport to measure the same thing. Next slide, please. Of the 347, 76 met our criteria and were assessed to see whether they had sufficient focus on the 13 outcomes. Now, before you can evaluate a questionnaire from a statistical perspective, or what researchers call a psychometric assessment, to see if it's well designed and things like that, we first have to ascertain whether it's relevant for our purpose. In other words, does it reflect any of the 13 core outcomes? Now, to do this, we undertook a screening exercise where we compared the items in each measure, or each questionnaire, to the 13 core outcomes. We rated how close a match questionnaire items were on an item by item basis on a 4-point scale: inadequate, doubtful, adequate, and very good. Based on existing and frequently used guidance, we required that 85% of items in questionnaires needed to be rated at least adequate or very good for it to progress to further assessment. And for the researchers in the audience, that would have been content validity, internal consistency and responsiveness. This 85% threshold comes from the idea that it's actually quite unethical to use questionnaires where a proportion of items have sort of minimal or no relevance. And just to clarify, when we were using this 85% figure, these questionnaires could relate to one core outcome item or all of them. We were just looking for how relevant each questionnaire was, either in part or in a best case scenario for all 13. The first screening step involved a total of nearly 18,000 assessments. Each measure was assessed by 2 researchers, and we calculated that there was an agreement in nearly 96% of cases. Where there was disagreements, they were subject to discussion between the 2 researchers who undertook the assessment, or a 3rd researcher was brought in to make a decision. Next slide, please. So this is what it looked like for the researchers undertaking this task. It looks a bit like a heat map or a game of Tetris for those of you who were around in the 90s and owned a Game Boy like myself. But on the horizontal axis, so that's on the left-hand side, you probably can't see, but it's the 13 core outcomes. On the vertical axis, on the top, we placed the items in all of the questionnaires. So the example on this slide shows a questionnaire called the Engagement and Independence in Dementia questionnaire. We simply compared each item on the left with the items at the top, trying to identify where there was a good match. Green denotes very good, orange denotes adequate, yellow doubtful, and red inadequate. We did this for each of the 76 measures, which I said earlier involved nearly 18,000 item by item assessments, with each questionnaire being assessed twice. Now, I don't know many people who are fans of Excel spreadsheets, and I think I can speak for all involved that we all had kind of square eyes by the end of this task. Next slide, please. So what did we find? Well, quite amazingly, no questionnaire passed this initial screening exercise, and therefore no wider statistical assessment could take place. I'll just spend a few seconds reflecting on that, and I will just run through the findings and tell you what I think it means. So while no questionnaires met the criteria, a small number scored far better than others. And interestingly, many of the frequently used and well-known measures scored very badly indeed. Now, this table on the slide shows the top 10 questionnaires that covered the most items, or most of the 13 core outcomes. The most relevant questionnaire to measure the 13 outcomes by some considerable distance was the Engagement and Independence in Dementia questionnaire that was featured on the previous slide, or the EADQ as it's shortened to. This was developed by Charlotte Stoner and colleagues and published in 2018. The EADQ has adequate or very good for 7 of the 13 outcomes. That's just over half, obviously. And overall, 19 of the 26 items in the EADQ were considered to be very good or adequate. That's just under 75%. So it falls short of our criteria, but not by much. And while we didn't conduct a psychometric assessment of this questionnaire, this has already been done by the questionnaire developers in a publication, and it demonstrated strong psychometric properties, essentially meaning that it's a well-designed questionnaire. But the big story is that a lack of an existing questionnaire for the core outcomes is highly significant. And because the best available match only covers half of the 13 and is also very new, it must be the case that researchers have not been assessing the 13 core outcomes very well, if at all. Now, we think this provides a new way of looking at the evidence in existing literature. It's almost a running joke in the dementia research community that trials often show little or no effect. Of course, it might be that the interventions or the things being researched aren't very strong or linked to beneficial outcomes, but it might also be that researchers are measuring the wrong things that aren't important to people living with dementia. Our study not only signposts researchers to new and important outcomes that are important to people living with dementia, but it also highlights a need to develop a new measure or questionnaire that can be used to capture information and data on the 13 core outcomes. Now, we think this has the possibility of revolutionising the quality of evidence in dementia research, and therefore over time may lead to faster and better improvements in policy and practice. Go to the next slide. I think I'm handing back to Siobhan to wrap up the webinar.
Thank you, Andy. So we believe that focusing on these 13 core outcome areas and measuring them consistently will increase the quality of evidence and be responsive to what people living with dementia value. As researchers, we want to ensure that interventions are evaluated robustly and rigorously so that policymakers, those making the decisions about what services to fund or how they should be configured, have the best evidence to make those decisions. And in those evaluations, it's important that we ensure that people living with dementia have their voices heard. What matters most to them is really what ought to be measured. And then we can truly influence policymakers and ultimately influence what gets provided for people living with dementia and those who support them. This study provides a practical resource for those designing dementia research trials. Being able to measure the cause items would herald a paradigm shift for dementia research, be responsive to what key stakeholders value, and enhance the ability to make comparisons. And finally, improving the quality of dementia research evidence is a vital step in improving dementia care services within the health and social care system. Next slide, please. Next slide, please. Is it coming? Thank you. Oh, right, so these are just the study references. So if you want to look more at the papers that we've written, you can do so. I'm sure the slides will be available after the event. Next slide, please. And thank you to all our co-researchers. And next slide, please. And thank you to all the study team and everybody who participated in the study. Next slide, please. And thank you all for listening, and please do get in touch if you want to know more, or if you don't get your question answered after this session, when we get to the question and answer session. Thank you.
Thank you so much, Siobhan and Andrew. That was really great. Debbie, if I'm going to do the Chris Whitty now as well. I want to join the club, so could you do next slide, please? Just the Q&A. So we've had loads of questions here already. So it sounds like a really large study and long-term study that you've undertaken. Really great. So we've got a few questions here. I think I'm going to start with the cartoon questions, because that seemed to generate a lot of interest from the audience. So positive comments, for example, where can the cartoons be found? Siobhan, Andrew?
So on my shelf here. So yeah, we haven't made them public, but you know, if people think they have a use for them, then just please do get in touch. We have produced, let's see if I've got any. I usually have them on my whiteboard, but we did also produce some materials. So we have copies of these. We have PDFs versions. We have like little postcards of the 13 items. This doesn't show it up very well at all, does it? And then we've got an A4 sort of poster as well that includes the cartoons. So we're very happy to share those. So yeah, if people have got any ideas, get in touch. And I'm sure Tony Husband himself, he's active on Twitter. If you want to follow him, he does a lot of work in this area, and I'm sure he'd be very happy to follow up with you as well.
Great, thank you. And there's one question, was adding the cartoonist to the sessions difficult to get through ethics?
I don't recall that, unless you do, Andy.
No, I don't recall it being difficult at all, actually.
No, we just described the process and how it would work. And yeah, that definitely didn't come up as any issue. Often in ethics committees, there are usually issues that are raised, but that certainly wasn't one of them, and nor should it be either.
Mm-hmm. So very positive comments about the cartoons to really make it, as opposed to us researchers, we tend to use the good old paper usually to share our findings. So it's nice to have that additional way of sharing research outside of the academic bubble. One question was about how did you recruit to the study?
So, Andy, do you want to take that? You've probably got better memory than I have.
Yeah, we used lots of mechanisms really, so including joint dementia research, which Siobhan's mentioned during the webinar. We recruited through local and national dementia cafes and organisations and groups. Health professionals went to a couple of NHS trusts in the Northwest and opened it up nationally as well. Just trying to think if there were any other means that we used to recruit from.
Yeah, we used some social media as well. Yes. And putting up posters as well. I think we also did that. But all these are sort of outlined in full in the papers. So if you want to go and get more detail and not just rely on our memories.
Yeah, great. And an interesting question about the wider applicability of the outcome measures as well. Any predictions on how these outcomes may translate to BAME and marginalised communities?
That's a really good question. I think that's really another piece of work that needs doing. So I remember being said at one of the meetings that we went to about core outcome set development is just like trials. Just because there's been one trial done doesn't mean to say that's the definitive trial. You often need multiple trials, and then you conduct a systematic review and you look at the evidence properly. So this is one core outcome set. So you could potentially do other core outcome sets for different countries or different communities. And so this is really just a start, I think.
Great. There's also a question, well, there's lots of questions here. Okay, let's have a look at this one. Do you consider the progressive nature of dementia and the impact this has on effectively taking part in research that uses questionnaire? How do you look to overcome these issues, so the severity changes of dementia?
Andy?
Yeah, well, in this project, Siobhan spoke about the Delphi survey. So we worked alongside people living with dementia to ensure that was an accessible questionnaire, and it was administered with the support of researchers. So it wasn't just like sent out by email or a paper version sent in the post. We would go to people's houses to help them complete it. But I mean, I do think questionnaire design in the field of dementia is a huge issue, and often one that probably gets swept under the carpet, given that a lot of the questionnaires, I think, are quite inaccessible. I mean, that was some of the feedback we had. For the systematic review, we had feedback from our co-researchers on some of the tools that featured in the top 10, so the highest scoring tools. And some of the comments were from recollection that, you know, taken together, they would be too long, too burdensome to complete, but also quite tricky to complete. They're not formatted particularly well, and I think it's an issue that researchers need to give serious consideration when designing questionnaires in the future. Definitely. Yeah.
Okay. And in terms of the usability of that core outcome set, question is about, are there any plans to use the research findings to evaluate dementia care on inpatient wards?
Not as yet. I haven't got any plans for that at the moment, but that sounds like a good idea. Although when you say inpatient wards, so We have also worked on another study looking at dementia training in hospitals. So that's a parallel study that ran alongside this study and was funded from the same source, and was part of the Neighbourhoods and Dementia study. So we are currently writing up the findings from that study, but we didn't use this these items to evaluate anything there.
So would there be applicable though, considering it's focused more on people living in the community and not in the clinical setting?
That's right. I mean, we did make a distinction and wanted to apply these to people living in the community. Of course, people living in the community then go into hospital. So I think, you know, different settings would need a specific, different measures. But there's no reason to say that once somebody goes into hospital, all these 13 outcomes aren't still relevant. I'm sure they will be.
Yeah, I mean, when I was presenting this work at a conference a few years ago, I think I had a field with a question from a pharmacist who kind of demonstrating an interest in this work in the context of drug trials, for example. And even though this study wasn't designed with that in mind, then you know, perhaps it has wider applicability than we have envisaged. I think.
Mm-hmm. Great.
Yeah.
And one more question as well about how that can actually be used. So the knowledge you've gathered, the findings from your study, how can we use this knowledge in practice now to assess our interventions? Ask all 13 outcomes? How would we measure this?
Oh, that's a lovely question. So I think we really do need to do a bit more work, I think, in developing a measure. And that is something that we certainly intend to do and apply for further funding to do. It wouldn't be difficult to actually construct the measure, but we need to apply for the funding to validate it and to do the work around making sure that it is doing what it says it's going to do, and it stands up against other measures as well. And going through the different aspects of validating the reliability and whether the measure can actually look at changes over time as well.
I think as well, it's worth saying that like the rationale of doing a core outcome set study is to establish, you know, which measures should be used as core across all trials. And when there, as Siobhan mentioned, you know, when there is one developed that focuses on these 13 areas, it's really as well up to, there's an obligation on researchers as well to use it as well. So it not only researchers, really, the whole research community, I think, it's an obligation there as well.
Yeah, I mean, I think we, as researchers, we all know that when you're involved in putting a grant proposal together, and often you're doing this with very little time, and you're having to make decisions on which outcome measures you're going to be using. I think that's where having a core outcome set to be able to go and look at that and see not just what other studies have used, because often that's what's happened. People don't really necessarily know which outcome measures to use, so they've plumped for the ones that they think are the best ones, but they've not necessarily had the benefit of all that prior research. So I think it's a useful tool. The whole series of papers that we published are useful for people to go through, not just, you know, thinking about the 13 outcomes, but looking at the list of outcome measures that is available, and also going back to the long list of items. You know, there were 54 items in the Delphi, so you know there will be other things in there that people that are still important to people, just because, you know, we've identified the 13 most important that were identified through the consensus methods that we used. but if there were, you know, a different population, they might actually think, well, actually there's a few more in there, in that 54, that we should have put in. So I think it's up to researchers to interrogate that research and look at it and decide for themselves which things they want to be looking at.
Yeah, and I know we've got a lot of health and social care professionals in the audience as well, which is fantastic. And I suspect this question comes from one of them, and it's relating to this previous question as well, Siobhan and Andrew. So what advice can you offer to practitioners who need to measure the impact of the services they offer, and they do not have the opportunity to engage external evaluators?
I think that's a really good question, and I think probably a lot of practitioners will come up against this because they don't have the time to look at, you know, what measures are out there, won't necessarily have the skills to look at that. Well, these resources could certainly be used for that, and there isn't really any reason why these measures couldn't be used in practice as well. And I guess it's about whether systems can accommodate the measures as well, and how you're going to use the data. There's lots of questions, I suppose. There's lots of, you know, if I was speaking to the person who has asked that question, in order to answer it properly, we'd have to have a detailed discussion about what it is they needed in order to really truly answer it. But happy to answer any questions if people want to email after the event.
Yeah, and I think one more question, well, it's two questions. I'm going to try and pick them up together. So people are wondering about the different population groups of people living with dementia, so those that might be a bit more difficult to engage with. For example, I have one comment here. Well, you have recruited, but the comment is, would you be considering recruiting from people who are isolated and whose voices are not always heard? Some people don't like going to groups and find it hard to accept the diagnosis.
Yeah, so when we were recruiting, we of course would definitely include, you know, anybody who fitted our eligibility criteria. So if they were basically living in the community and had a diagnosis of dementia, then, or even just, you know, had dementia, you know, we knew that they had dementia, that was part of our inclusion criteria. Didn't matter where they lived, as long as they were living in the community. But that's a very common problem, where people find it difficult to accept the diagnosis and might not want people to know that they've got dementia. And I think these sorts of events and all the work that you're doing, Clarissa, I think is and all probably the people who are listening as well, is so important to raise awareness and get rid of that stigma. So there won't be as many people in the future who feel like that.
Yeah, great. So there's a couple more comments, but I think it'd be just generally saying people are looking forward to seeing further findings from your research that you're still working on, Siobhan and Andrew. So thank you very much for some really interesting questions and comments from the audience, and thank you for really useful and interesting discussion, both Siobhan and Andrew, and thank you for sharing your work at our webinar. That's really great. So the recording of this webinar will be on YouTube in the next couple of days, and I'm happy to share that via social media and anyone who's attended. And if I could do the last Chris Whitty, please, Debbie, and next slides, to just introduce our May webinar, which will take place on the 19th of May during Dementia Awareness Week. And I've already posted the link to the Eventbrite in the question and answer as well. And the focus of this webinar will be on how can we change the home environment to reduce fall risks in older adults. And Dr. Richard Foster from Liverpool John Moores University will be giving this talk in May. So thank you everyone for joining us, and hopefully see you back in May. Okay, bye now.
Thank you, bye-bye.